A very good morning, guys. Very good morning. So I think the previous class we stopped at memantine, right? So we are discussing about Alzheimer's, right? We are discussing about Alzheimer's disease. Once again, I will just tell you the treatment. You just hear it clearly, okay? Once again, I will tell you the treatment. So we'll start with Alzheimer's, right? We'll start with Alzheimer's disease. I think you know some of the features of this Alzheimer's disease, right? There's the deposition of some sort of proteins, different types of proteins. They are called alpha amyloids, beta amyloids. Different types of protein sheets are deposited in the brain, and some sort of things like you have amnesia. The patient will complaining of sometimes it's retrograde or sometimes it can be anterograde. So that all things will be discussed in the pathology. But for the pharmacology's sake, Alzheimer's disease, the drug of choice is cholinergic drug. Cholinergic drug is the drug of choice. What is that cholinergic drug? That is donepezil. Very important question. It's a potential MCQ you might get in the Neet PG, not in Inicet, but you may get in a Neet PG. And one more drug is rivastigmine. What is rivastigmine? Anticholinesterase. Anticholinesterase, okay, or also called cholinesterase inhibitor, right? Rivastigmine. And one more drug is galantamine, right? One more drug is galantamine. Now you can add another drug called memantine. You can add one more drug called memantine, which is a NMDA blocker. It's a NMDA blocker. It's a NMDA blocker. What is NMDA? N-methyl diaspartate blocker. But where you will add this memantine? In moderate to severe cases. If the patient is having a Alzheimer's condition which is moderate to severe in condition, then you can add memantine with the cholinergic drugs, right? So that's it. And we can also have some sort of newer agents which were established recently. Newer agents also we can just keep it a part of the treatment, that is beta amyloid blockers. Previously I said no, there is a deposition of beta amyloid proteins in the CNS, so we can give beta amyloid blockers. But if you ask me what is the drug name, that is aducanumab. It is aducanumab. Just wait. My pointer is, see, aducanumab. It's a very important thing. Why? Because newer drugs are always potential MCQ. Newer drugs are always potential MCQ in Neet PG as well as in the Inicet also. Okay, so newer drugs is very much important, right? So aducanumab, it can be used in mild cases. Aducanumab in mild cases, right? So up till there it's okay with Alzheimer's disease. Now we'll go on with treatments for some other disorders, right? Okay, so we'll write here the disorder name, we'll write here the drug of choice, and here we'll also make some other considerations which we can make with this consideration, right? Okay, so we'll start with the trigeminal neuralgia. It's one of the most prominent CNS condition that you see in most of the patients, right? So what is the drug of choice in trigeminal neuralgia? Remember, it is carbamazepine. Right? Now one more condition is restless leg syndrome. If you ask me the treatment, it is gabapentin, one of the most famous drug in CNS, gabapentin. But you can also go for a second drug which is pregabalin, right? So these two drugs you can use either in restless leg syndrome or also in herpetic neuralgia. So after post-herpetic condition, you may get a neurological pain. It may subside instantly, or it may occur after some period of time. That is called herpetic neuralgia. You can give either gabapentin or pregabalin. Either of it is sufficient. But what is the mechanism of action? That is important. It's a potential MCQ. What happens is there occurs a binding to alpha to delta 1 subunit of presynaptic calcium channel. Now if you ask me, sir, where is this located? It's simple. For example, it is presynaptic. Here you have sodium gated channel. Here you have calcium gated channel, right? So this is the presynaptic calcium channel. It's okay? It's okay up to there? Clear? Calcium channel, right? Now what are some other conditions? For example, if the patient is suffering from psychosis, what is the drug of choice? Psychosis, always the drug of choice is atypical antipsychotics. But if it is a resistant psychosis, if you go for treatment but still the psychosis is not vanishing, so if it is a resistant psychosis, then the treatment of choice will be clonidine. Then the treatment of choice will be clozapine. Not clonidine, it's clozapine. Why? Because what is clonidine? Clonidine is a alpha activator. Clonidine is a alpha receptor activator. So where we should use clonidine? Clonidine is used in hypertensive cases. So what is the complication of clonidine? Previously we already spoke. Clonidine withdrawal hypertension. After using or after utilizing clonidine for a short period or some period of time, if you withdraw the drug clonidine instantaneously, it leads to causage of withdrawal hypertension. So that is called clonidine withdrawal hypertension. It is one of the most common side effect that is seen with clonidine, utilization of clonidine, right? But for resistant psychosis, use clozapine. Don't confuse with the drugs, because in the options you will get clozapine and clonidine also. Clonidine is something which deals with hypertension. Clozapine is something which deals with psychosis. Remember, both are two different drugs for two different systems, right? Now some other conditions like ADHD. What is ADHD? Attention deficit hyperactivity disorder. What is the drug of choice? Methylphenidate. But you can use methylphenidate, but if you ask me, methylphenidate has some serious drawbacks. What are those? The patient may land up to tics, and usage of methylphenidate may leads to abuse potential, means the patient may get addicted for methylphenidate drug. So always use methylphenidate with caution. If the patient has ADHD with Tourette syndrome, then the drug of choice changes. It will be clonidine, not methylphenidate. If the patient only has ADHD, you can go for methylphenidate. But if the patient has ADHD with Tourette syndrome, you should give treatment of clonidine, right? If the patient have ADHD with a family history of drug abuse, if a patient have ADHD with family history of drug abuse. Now previously we spoke one drawback about methylphenidate, that is it has a high abuse potential, means the patient may get addicted to it. So if the patient family has a history of drug abuse, can you give methylphenidate? No, you can't give, because it has an abuse potential. So you give another drug called atomoxetine, not etomidate. Etomidate is wrong. It is atomoxetine. It's atomoxetine or vilojoxin. It's viloxazine. Sorry, viloxazine. 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 Right. Now, what is the mechanism of action of this atomoxetine or viloxazine? They are selective norepinephrine reuptake inhibitors. Selective norepinephrine reuptake inhibitors. You understand? Selective norepinephrine reuptake inhibitors. Now, if you ask me, if the patient has tics condition associated with Tourette syndrome, then the drug of choice will be tetrabenazine. I think previously, when we are studying for the initial classes, when we are going on with the initial classes, where did we discuss tetrabenazine? We discussed somewhere when we are combining all sympathetic, parasympathetic, parasympatholytic and sympatholytic. When we are doing a study or class on these drugs, we just discussed about tetrabenazine as the drug of choice for tics associated Tourette syndrome, Just remember this fact. Now, up to this one, it's okay. But we have one more condition which is most commonly we see in the generalized population, something which you observe daily, day-to-day life, that is migraine, headache at either of the cephalic regions, prominently at the parietals. Now, what are the drugs for migraine? So, first of all, I just want to tell you one thing. What is that? I just want to tell you the real mechanism. Actually, it was a concept. It's not a confirmatory. It is a concept. Most of the pharmacologists or most of the clinicians believe, according to the research that has occurred, it is just a concept. It's not confirmatory. So, we'll discuss the concept first. What is that concept? So, the concept is, this is cranial nerve 5 nucleus. So, we have something called the receptors. Which receptors? 5-HT, 1B or 1D receptors. These receptors, they act on the ganglion. How do they act on the ganglion? They are actually inhibitory receptors. Remember, they are inhibitory receptors. Now, this ganglion, if activated, it leads to utilization or production of CGRP. What is CGRP? Calcitonin gene related peptide. Now, this CGRP goes and acts on CGRP receptor. This is CGRP receptor. Where is this CGRP receptor present? It is present on the blood vessel. It is present on the blood vessel. Now what happens is, when this CGRP receptor acts on the CGRP acts on the CGRP receptor, it causes vasodilation in the blood vessels of, where are these blood vessels present? Meninges. So this CGRP protein, it causes meningeal vasodilation. CGRP causes meningeal vasodilation. This meningeal vasodilation in turn leads to cerebral edema. In turn leads to meningeal edema. It leads to meningeal edema.